Hello, my name is Sharon Donn. I am a family nurse practitioner pursuing my doctorate in nursing practice at the University of South Alabama. The following presentation will review my scholarly project titled Reducing Heart Failure and Chronic Obstructive Pulmonary Disease Readmissions. This quality improvement project has been ongoing since August of 2017 and has been designed and implemented under the guidance of Dr. Shannon Harris and Dr. Corey Sessoms. Statistics show Medicare patients with chronic conditions have an average readmission rate of 20% within 30 days of hospital discharge. Readmissions generate approximately $17 billion in potentially avoidable costs each year. A substantial fraction of healthcare dollars are jeopardized by superutilizers. Superutilizers comprise a mere 10% of the U.S. patient population, yet they utilize nearly two-thirds of healthcare resources to adequately manage their medical conditions. In 2012, the Centers for Medicare and Medicaid Services, or CMS, developed a program linking reimbursement penalties with premature readmissions. Chronic obstructive pulmonary disease, which will be mentioned as COPD for the remainder of the presentation, and heart failure are two of the 7 diagnoses tied to such penalties. The focus of this study centers on patients with COPD and heart failure. Hospital readmissions are a topic of national concern. Not only do readmissions increase the prevalence of patient dissatisfaction, they also contribute to suboptimal outcomes and rising healthcare costs. Superutilizers are characterized as patients treated in medical facilities multiple times each year. Costs associated with these encounters contribute to the disproportionately high resource utilization seen among this population. Often falling within the parameters of the superutilizers are the 5.5 million Americans diagnosed with heart failure. This subset of patients also require a large fraction of healthcare dollars for medical management and are cited to have readmission rates exceeding 65%. While COPD patients have slightly less staggering statistics, they are still considered significant contributors to rising healthcare costs with cited readmission rates between 10 and 20%. Superutilizers within High Point Regional's system have a readmission rate of 31%, which was identified as an unacceptably high statistic. The financial impact tied to chronic disease management has become an area of national concern. Thus, in an effort to encourage hospitals to implement measures to reduce readmissions, CMS designed the Hospital Readmission Reduction Program. The Hospital Readmission Reduction Program links reimbursement payments to quality care measures. The design penalty structure permits Medicare to decrease reimbursement payments by as much as 3% when 30-day readmission rates are linked to the following diagnoses: acute myocardial infarctions, COPD, heart failure, pneumonia, coronary artery bypass graft surgery, total knee and/or total hip arthroplasty. The purpose of the study is to determine if incorporating transitional care in post-discharge interventions will add value to readmission reduction efforts for superutilizers with heart failure and/or COPD. The main project goal is to decrease 30-day post-discharge readmission rates by 10% within the superutilizer population, and the overarching project aims are to decrease hospital costs related to readmissions, reduce Medicare penalties, and improve patients' quality of life. The QI initiative was a joint effort between UNC Healthcare's High Point Regional Hospital and the affiliated Transitional Care Clinic. High Point Regional is a 351-bed acute care facility located in North Carolina. The Transitional Care Clinic is a provider-staffed office that offers time-limited complementary care as an adjunct to primary care for patients discharged from the hospital without a primary care physician. The interventions for this project took place within the Transitional Care Clinic. 15 patients were enrolled in the study based on the following inclusion criteria: a diagnosis of heart failure and/or COPD, patients defined as superutilizers, those who were 18 years of age or older, and patients with access to a telephone. Several tools were utilized in the study design, including the Iowa model, which was used to determine project value, lean methodology, which was followed for study design, and the Karnofsky Performance Scale, which was used to monitor changes in disease state among patients. Retrospective chart reviews were conducted on more than 200 medical records to choose appropriate patients for the study group. Three study interventions were chosen for the project. The first was weekly follow-up phone calls made to patients by the APRN between days 1 and 30 post-discharge. The second was to conduct assessments with the Karnofsky Performance Scale during weekly calls to determine disease state, assign corresponding scores, and assess for decline in patient status in an effort to intervene as necessary. The third and final intervention centered on educating patients to appropriately use the Ask Me 3 method of communication. To elaborate on the tools used for interventions, we first consider the Karnofsky Performance Scale, which moving forward will be referred to simply as the KPS. The KPS is a validated tool designed to assess three aspects of disease. Based on given answers, the patient receives a score between 0, indicating death, and 100, which corresponds with no evidence of disease. The three categories considered in this tool are symptom burden, the level of assistance needed for patients to complete their activities of daily living, and their current degree of disability. Once patients answer these questions, the APRN assigns a given score to them. If the APRN identified a score of 60 or less, which indicated a moderate degree of disability and symptom burden, the patient was offered a provider office visit. Beginning in week 2 of the study, the APRN began educating patients on the Ask Me 3 method of communication. This form of communication encourages patients to ask providers the following three questions during each provider encounter. Written in layman's terms, the questions ask, what is my main problem? What do I need to do about it? And why do I need to do those things? The National Patient Safety Foundation developed the Ask Me 3 tool to encourage patients to take ownership of their health and pursue greater understanding regarding their disease process. Incorporating these questions into medical dialogue improves health literacy and clarifies concepts communicated between providers and patients. The data collection process for the project took place with retrospective chart reviews. All data gathered during the intervention period was recorded in the EMR to aid in such reviews. Variables considered included the following: 30-day readmission rates compared between control and study groups, weekly KPS scores, patients who required additional clinic visits beyond initial post-discharge appointments, the percentage of calls made by the APRN which resulted in successful contact, the number of patients the APRN was able to educate on the Ask Me 3 method of communication, and the number of patients who remained active in the study for the full duration of 30 days. SPSS software was used for statistical analysis of data generated from the EMR. Calculations utilized included measures of central tendency, cross-tabulations, Pearson's correlation coefficients, and Spearman's row testing. The level of significance chosen for statistical analysis was 0.05. Fifteen patients initially gave informed consent to enroll in the study. However, 3 chose not to participate in the weeks following their initial call. Demographic data indicated 73.3% of patients included in the study group were female, and 26.7% were male. The mean patient age was 58.67 years with a standard deviation of 11.24. 26.7% of patients had a diagnosis of heart failure, 53.3% had COPD, and 20% had a mixed diagnosis of heart failure and COPD. 40% of patients reported insurance coverage through Medicare, 6.7% reported private insurance coverage, and the remaining 46.7% were uninsured at the time of the study. Study results related to interventions showed 65% of calls made by the APRN resulted in successful patient contact, while 35% of calls remained unanswered. Frequency calculations determined mean KPS scores during initial patient calls were 81.33 with a standard deviation of 11.25. KPS scores for the remaining study period showed mean scores of 75 during week 2, 74.44 during week 3, and 77.78 during the fourth and final week. 13.3% of patients in the study group required additional clinic visits due to decompensation, and of those, 100% had KPS scores of 60 or less. Ask Me 3 education was completed with 73.3% of participants, while the remaining 26.7% of patients were not educated. This was primarily due to the inability to contact patients. When considering total 30-day readmission rates, 20% of patients from the study group were readmitted during the intervention period, indicating an 11% reduction in readmissions between the study and control group. Despite the fact that all patients enrolled were asked to contact either the transitional care clinic or the APRN prior to seeking inpatient care, all refrained from doing so. Beyond those readmitted, an additional 13.3% of patients had an emergency department visit resulting in discharge. 100% of ED visits occurred between days 15 and 30 post-discharge. Several statistically significant findings were discovered during the data analysis phase. A Pearson correlation coefficient was calculated to determine the relationship between the elapsed time post-discharge, calculated in days, and the incidence of patients returning to the ER for care. A strong positive correlation was found, indicating a significant relationship between the two variables. In this study, the more days elapsed post-discharge, the higher rate of readmissions. A second Pearson's correlation revealed a significant relationship between initial assessment diagnoses, heart failure, COPD, or both, and an alternate or unrelated readmission diagnosis. A strong positive correlation was found, indicating a significant linear relationship between the two variables. In this study, readmission diagnoses were unrelated to the initial cause of admissions. A significant correlation was found between diagnoses and the need for additional clinic appointments, indicating a linear relationship between the two. In this study, participants with COPD were more likely to require additional clinic visits than those with heart failure or a mixed diagnosis. Finally, a Spearman's-Rowe test was run to determine the relationship between a patient's initial KPS score between days 1 and 7 post-discharge and readmission rates. A positive correlation deemed statistically significant was found. KPS score ratings assigned between days 1 and 7 post-discharge are related to readmissions. While not deemed statistically significant, a weak positive correlation was found with the Pearson's correlation, determining the relationship between patients educated to use the Ask Me 3 method of communication and those readmitted, thus suggesting this form of education may impact readmission rates. Contextual barriers to implementation were primarily related to inconsistencies in patient participation and staffing constraints at the transitional care clinic. These staffing challenges were unforeseen during project design and came from the unexpected loss of a provider, which affected scheduling availability. Identified study limitations included the small sample size of only 15 patients, a narrow population scope that focused mainly on the lower socioeconomic subset, thus not giving consideration to those with more available access to resources, and the timeliness of the study. Interpretation of results. Post-intervention 30-day readmission rates among the study population declined by 11%, exceeding the project goals of reducing readmissions by 10%. KPS scores assigned post-discharge were found to be a significant contributing factor to readmissions. Although this intervention was found to be statistically insignificant, Ask Me 3 education was shown to have a positive correlation to readmissions. And finally, no relational ties were found between the number of follow-up calls answered and readmission statistics. This concludes a presentation on reducing readmission rates in the heart failure and COPD superutilizer population. I would like to take this opportunity to thank you for your time and attention. Please refer to the remaining slides for reference information.